Can you hear me now?
जी.
अब ठीक है बस?
Yes, it's better now.
बेटर है या ठीक है?
उस तरह की क्वालिटी नहीं आ रही है. I don't know.
Shall I change my
But
place then? Let me change my place and maybe I don't have enough Wi-Fi signals here. Let me just COVID-19, I think everybody's very scared of it. We are still struggling to find out how we treat, how we're doing things. So I was talking about इमरजेंसी मेडिसिन में जब पेशेंट्स आते हैं तो हमें क्या करना होता है. तो सबसे पहले तो हमारी अपनी जो सेफ्टी है, your own safety is most important. You're not supposed to go in and out from the cubicle wearing the same gown and gloves and everything. So you have to dispose of everything before you come out, because you cannot spread infection from one place to another. In the emergency department, our main aim of this session is to recognize patients who can be discharged home, who can be kept in, and it's basically your own clinical judgment, your own clinical knowledge ke ye isko COVID ho sakta hai and whether he needs to stay or not. So I think COVID, जैसे कि आपको भी पता ही है कि इसका जो कोर्स है वो हर एक में different है. I mean, I have seen elderly people getting better. I have seen young people dying with COVID. So there is no clear-cut guideline. There is no clear-cut. You cannot suspect कि हाँ ये patient ठीक हो जाएगा and ये नहीं ठीक होगा. Obviously, people, we all are at risk, and people who have got underlying health conditions, they are more at risk. So there are three types of patients who can present to the emergency department. We can categorize them in either mild, moderate, or severely ill. The presentation these days is very, very different, especially in elderly people who sometimes have got no respiratory symptoms, but they are coming with just being delirious, just being confused, and you find out that they have got COVID. We have got the facility to do a test which gives you the result in an hour, so which is quite helpful, and then you can treat them. But people who are suspicious and not confirmed in the meantime, we keep them in a different category so that we don't mix them up with the other patients or other areas. Mild cases में patient obviously जो उसके symptoms हैं उसमें यही है, headache है, आपको respiratory symptoms हैं, malaise, myalgia, loss of sense of smell, taste, or headache, fever. But not all of the things are present. They might just present with one thing. They might not present with anything because it can be completely asymptomatic. But asymptomatic people, luckily, they don't come to hospital. They can only be found out on contact tracing. तो इसलिए हम उसके बारे में तो हमें परेशान होने की जरूरत नहीं है. लेकिन जो patient, they walk in and they've got some shortness of breath, maybe on exertion. They look well, they have got a bit of temperature for a few days, and they want to make sure that they haven't got COVID. So we assess them, we talk to them, make sure that how their initial vitals are, their blood pressure, pulse, their respiratory rate, their saturations. And we do check their saturations after making them walk for like 20 steps. And if they desaturate less than 94 or 95 in a young, healthy person, then we ask them to go home, isolate yourself, and a general advice. But it is very important to give them the clear advice that when to return and what to look for, what are the symptoms that they need to watch when they need to return, and which are obviously the deterioration of their symptoms. And if they are not have got any place to isolate, then we sometimes have to admit them in elderly people, or here is not a big problem because mostly one family lives in one house, not in Pakistan where multiple people live in the same household and you've got a risk of spreading. So self isolation, usual जो उसकी management है, मतलब fever के लिए paracetamol है, symptomatic management and general advice कि आप मतलब rest and good diet and continue to have fresh air and make sure that they check their saturations now, you know, we can provide them from hospital, but in Pakistan they are already, I think lots of places are giving the SATs probe. So giving them the good instruction that when you monitor the SATs, they need to be educated that how to monitor the SATs. They should have, they have to have for a few minutes the saturation probes, and then when it fluctuates and then it becomes stable, only then it is, you know, definite reading. But I think it's very difficult to teach in your setting to every patient because they might misinterpret. And also if saturations are low, then it's not always that if they are feeling better in themselves and they're not feeling short of breath, but their SATs are 94, 95, then it's a clinical judgment that how unwell they are, whether they need to go to hospital, or whether they need to stay. Only one element of saturation. You have to combine the whole picture and then assess. I mean, if they have got fever, if they are lethargic, they look tired and they desaturate, then you think about maybe a little bit of treatment may help. In that case, different places have got different guidelines. They do send them home with 3 days of antibiotics. Here it was initially doxycycline, which we were using for 3 days only just to prevent infections. Slightly symptomatic people, they go home with 6 days of dalteparin, low molecular weight heparin. We were discharging them because we have seen lots of PEs and people returning with the collapse and having a massive PE. So I think whatever, आपकी वहाँ पे कौन सी एंटीबायोटिक्स ज्यादा, मेरा ख्याल है जिथ्रोमाइसिन बहुत थी वहाँ पे पाकिस्तान में.
Azithromycin and moxifloxacin 5 days, azithromycin for 5 days. Moxi कभी वो 7 दिन के लिए भी दे देते हैं, 500 once a day.
जी. तो वही azithromycin भी दे रहे थे, मतलब कोई सी भी एंटीबायोटिक. लेकिन I know कि बहुत से लोग वहाँ पे mistreat भी हो रहे हैं. They start steroids straight away, which is not a good thing. In a asymptomatic patient, having steroids, it suppresses the immune system and can cause more issues. So steroids is not for everyone. If they are desaturating, if they've got comorbidities, then you don't necessarily on your initial assessment, you don't necessarily need to do a chest X-ray on everybody. You don't need to do bloods on everybody. If they are up and mobile and they maintain their SATs even after 20 steps, then you just give them 3 days course of antibiotics and general advice and dalteparin for 6 days and discharge them. And if they get worse, then they come back. So when they come back getting worse, then you've got more unwell looking patient. You have got less saturation, shortness of breath, fever. In young patients with maybe no underlying health conditions, if they have got health conditions, even then, if they look unwell, then you do the blood gases. We do chest X-ray first rather than going straight to CT. I would say that a chest X-ray is not always showing all the symptoms, which patient is symptomatic, but chest X-ray may be normal looking. So it's not a true reflection of their condition. So ideally they need a CT, which will show more infiltrations and more of their severity of the disease. So in that case, they will need antibiotics. We give them dexamethasone because it has been proven to have more anti-inflammatory effect. So 6 milligrams of dexamethasone IV, we give them that. And we do the VT assessment. So all the admitted patients, obviously, they will be staying in hospital, they will be on the bed, so they are likely to have PE, so we give them deltaparin, low molecular weight heparin. But as I said, in patients, if you discharging them, if they're not comfortable injecting themselves deltaparin, then you can discharge them with the rivaroxaban, but not in very young and healthy patients. Only if they are above like 45, 50, looking at them, if you suspect that they might get unwell, they might deteriorate, then you anticipate that they might be having any benefit of getting this rivaroxaban. Not every patient would need rivaroxaban. So 10 milligrams of rivaroxaban once a day. But if they are getting admitted, then yes, if they require oxygen. So again, A, B, C, D assessment, you start from A and you know that this disease have got A and B problem. So C and D usually stay okay, but D sometimes deteriorate because of delirium and confusion, and especially in elderly people. IV antibiotics or maybe oral antibiotics, dexamethasone is a steroid, and rivaroxaban or low molecular weight heparin, because they are going to be likely on the bed in a hospital. We monitor, the aim of giving oxygen is initially with a nasal cannula, so 3 to 4 liters. Via nasal masks. So aim is to maintain their SATs around 94, 95, so something in between where they are comfortable. But if they are deteriorating, if they require more oxygen, then you start non-rebreathe oxygen with a bit of more. And then in that case, you have to be a bit more careful, because you have to keep in mind that they might have got COPD and they are retainers. And if you are giving them too much oxygen, then it's not going to be of any benefit. So it has to be your interpretation that how are they maintaining their SATs. And in that case, yes, we will do a CT scan. We will check what the level of severity is there, and if there is any pneumonic patch, or if they are having on top of that infection or pneumonia, then you need a broad spectrum antibiotics IV. Fluids, yes, they are important. Hypoglycemia or hyperglycemic control is very important, which you need to make sure that you're attending addressing these issues. So these are the patients you anticipate that these are the patients that you might anticipate that they can go unwell. This is the right stage when you speak to them about their treatment escalation. I think we need to make some sort of decision at this point that how far are we going to treat, educate the patient that if they go unwell, this is likely to be the course of action. In young patients, it's very, very difficult to break these news and say that this is a disease which has got no treatment. We will just treat you symptomatically. You can either die or you can be surviving, or, it's very difficult conversation to hold, especially when the patient is ill. They don't have relatives around them. They don't have any family. So you kind of make that decision, because if a patient has got some underlying health condition and they're young still, like, for example, an underlying malignancy, so you will have to plan that if he goes more unwell or if he deteriorates, then would you intubate this patient? What is their consent? What is the discussion that you had with the patient? And then document it in your notes that how far is likely to be how likely is going to go. In more sick patients who are very short of breath, they are the most difficult ones, of course, and we think about intubation or CPAP, and if they are really looking low SATs and not maintaining with nasal cannula or their non-rebreathe mask, then they will end up having a CPAP, which I don't think that is available in your case. But we start them on CPAP.
We do have
and if they are having CPAP, yeah, I think last time we spoke in COPD, so you mentioned that it occurs in ITU. So
Mm.
ITU, when they, I think if we reach up to that level of CPAP, then you anticipate that this patient is going to go worse. And then involve the ITU team, involve the other specialties like medics. And so the initial management, again, stays the same from ABCD approach. You look after their airways, you make sure that you put oxygen on whatever the requirement is, either via nasal cannula or with the non-rebreathe mask. And if they maintain their SATs, then you move on to listen to their chest, get a chest X-ray done. Yeah, what's their respiratory rate? What's their work of breathing? Are they really struggling? Are you heading towards CPAP? Are you heading towards intubation, depending on how exhausted they are, how young they are? So it's all about clinical judgment, clinical decision making with the collaboration of your team members. And the basic guideline is, yes, they would need IV antibiotics. Yes, they would need dexamethasone. They would need some nebulizers help. If they are short of breath, then nebulizers do help in opening their airway. So all the supportive management in every ABCD thing, every support that you can give the patient and um, try and help them not to deteriorate. So IV lines and all the baseline bloods, which includes, LDH and D-dimer and other things. But so even if you do the blood test and they come back like raised D-dimers, but even slight raised D-dimers, you have to combine the whole picture of their clinical presentation and the blood tests to make sure that what's going to be the further management plan. So you are giving them a low molecular weight heparin anyway. So these blood tests would be for your baseline, because in case if you need to repeat them, then you can see that this can be a bit further deterioration, or are they getting better? So these are the parameters which you measure that to see if the patient is getting better or if they're getting worse. But because this is an A and B problem, so your visual analog is much more important, that how much are they struggling. It's very sad these days when we see patients dying because of shortness of breath, lack of oxygen. So oxygen is very important, which is going short everywhere, and people are struggling because they don't get, some people do get better after a bit of oxygen, and in a few days time, they don't get worse. So not every patient who needs oxygen need to stay in hospital, because that will expose them more. They are likely to catch more infections from hospital. So if they can manage oxygen at home, we teach them, then it can be possible to titrate the oxygen to maintain the SATs. In your country, I think there is a lot of family support, so people in the house can do things. But in our situation, sometimes the elderly people, obviously, they cannot manage themselves, so they have to stay in hospital. So it varies from case to case, from person to person, from every single case is different. So you can't, just like we normally see that these are the guidelines, you do this when it is this, when you do this, you do this. It's not the case in COVID. It's very much of a clinical presentation and your judgment and how they respond to the initial treatment, because you know that COVID is going to make its own course and it's not going to go away very quickly. And it has to be in the system for 10, 15 days at least. So 7 to 10 days are considered to be the most critical time, where you can assess that they're getting better or they're getting worse. So if they start to deteriorate, then you think about at that stage, if you think they are not getting better with the initial management, then you think about antivirals at that stage. I don't think antivirals have got any role in the urgent or early days, although some studies do say that a bit early antiviral have got some effect, but it's not proven. So I wouldn't say that, yes, on day 4, you should start this, on day 5, you should start this. It's very, very vague. So it all depends how the patients are. If I'm sending somebody home who has got maybe mild asthma, who have got mild COPD, but they are maintaining their SATs even after 20 steps walking, but they have got fever, they have got, they have got underlying lung conditions. There is no harm giving them dexamethasone orally for 10 days to send them home, because they are the ones who might get benefit from that. But if a person who's healthy and have got very mild symptoms and they're looking like normal, but they're just a fear of having COVID, should not be having steroids. So it's very much of a clinical situation and their underlying health condition when you anticipate that this patient is maybe at more risk of getting worse. So general response in young healthy population is they get better. It does its course. You do not need to have, if you are asymptomatic after a few days, then you have to complete your 10 days quarantine from the day of your test that you have done or illness. And then you don't need to have if you are asymptomatic, you don't need to repeat your blood test to say you are COVID negative. So if you are asymptomatic, you've done your 10 days quarantine, you are fine. You can move around, but still you can be carrier again, you can spread it. So face mask, distancing still is very important. You don't think that you have got COVID and now you are fine and you can do anything. That's not how it is. So you still have to be careful. People who are having vaccine, who got vaccinated, even the first or the second dose, they are equally again at risk. Although if they get COVID, they still can get COVID. They don't have the license not to have the COVID. But if they do get COVID, I think the studies say that they might get better and without any serious complications. But it's not the case that if you are vaccinated, you're not supposed to wear a mask or you can meet people who are all vaccinated. You still have to maintain social distancing. You still have to take all the measures, because you may be a symptomatic carrier and give it to somebody who has not been vaccinated. So don't imagine that this is a situation where you are free to do anything.
There's also that
Mainly, I think we should.
There is also that variants that are coming up. Even if you're infected with one
Yes.
variant, you still have to protect yourself from the other side because they are a little bit different. And there is some data that the vaccination, especially the earlier vaccination, do not protect totally against the other variants that are coming up.
Yeah, so I think all the vaccinations, none of them is 100% effective. Even Pfizer has got 95% efficacy, but it doesn't cover all the variants. Similarly, other variants in Pakistan, which vaccinations they're having, it's 65% effective. So it does not cover all the strains of this mutated virus. So it's very important that you stay away from people. And I think even Sinopharm is giving in Pakistan, or here there are two different AstraZeneca. So all the vaccines have got different things. People who are being vaccinated, there are lots of, I think especially in AstraZeneca, is it in Pakistan? AstraZeneca, you giving AstraZeneca?
Sinovac and
No.
Sinopharm are coming.
Okay, but here we have got lots of cases of brain clots after AstraZeneca. I think the reported cases are only 18, but now we have developed the guidelines for those as well, that if they've got headache between day 8 to day 25, then they need blood tests first. And if their platelets are low, then you do a D-dimer. And if the D-dimer is high, only then you do a CT scan. So there's a lot of fear, lots of anxiety among people, but I think people are still not looking after themselves. They're still meeting, everything is going on. And I think prevention is better than cure, but it's very difficult in Pakistan, which I am seeing, and sadly worried about the situation there, that how are they managing with the limited resources, and what's going on in India is very, very sad. if this happens, in any country, then it's very, very difficult to manage. So try not to reach to that level. I think whatever we can do, educate people, try not to mix with gatherings, avoid everything so that we can reduce this and get back to normal life. I think that's all really, because not many people, so I cannot really ask questions from people, but I can ask your opinion about treating COVID in
So
your.
yeah, I mean, main thing is prevention, number one. Number two is that even if you get vaccinated, you don't feel like you're immune to it because you can still get it. That's the main point. So you still have to continue
Yeah,
with all the precautions.
yeah.
Um, and number three is that जो चीजें बिल्कुल effective नहीं हैं उनके बारे में थोड़ी सी बात होनी चाहिए कि hydroxychloroquine, which some people are still using. There are a lot of homeopathic medications, especially turmeric
Colchicine
and
and
garlic and colchicine, ivermectin. They have proven non-beneficial for these patients. Some people are not using uh, the things that are actually have helped us is जो हम यहाँ पे भाप लेते हैं या जो वेपराइजिंग ट्रीटमेंट्स लेते हैं उससे और म्यूकोलेटर से जो म्यूकोनिल यहाँ पे आती है उससे म्यूकस की प्रोडक्शन भी थोड़ी अच्छी हो जाती है और यू आर एबल टू एक्सपेक्टोरेट. So these two things are
mhm.
actually important. There is some data that using nebulized or inhaled steroids, they also help decrease risk.
Okay.
So you can use that instead. और यहाँ पे एंटीबॉडी टाइटर का भी एक थोड़ा सा मैं बता दूं कि एंटीबॉडी टाइटर देयर इज नो रोल ऑफ डिटरमिनिंग हाउ मच टाइटर you have and whether you are actually protective. What titers are protective against reinfection. So there's a lot of people who are doing antibody titers कि ये हमारे अब टाइटर इतने हो गए हैं इतने हो गए हैं लेकिन वो ये कि every titer falls out after about 3 months time because it makes sense that you're making memory cells. You don't need active antibodies at that time when you're not actively infected. So वो antibody titer भी करवाने का कोई फायदा नहीं है. There's a lot of patients who actually do a negative COVID before they go quit their quarantine. That's also not recommended. They just, if you're asymptomatic for more than 48 hours and not using paracetamol or
Mhm.
antipyretics, then you don't need to, you can quit quarantine after that.
I think
Um,
there's a lot of fear in young population, and especially I have seen with all the relatives and family and friends that as soon as you get diagnosed with COVID positive, you just get all your blood tests done, you get your chest X-ray done, although you are feeling completely fine in yourself. But we need to think that we should not be wasting the resources. What's the point of having blood tests if you are completely fine in yourself? You are a young, healthy adult. Then it might be more helpful for the labs to run the test on those who actually need them, who need the urgent results. So not having a random medication, whoever takes the advice from anywhere, they just take it. So try and educate your family, try and educate your friends that this is not the way, trying to discourage this way of treating. And I think take one case individually, that how are you going to manage. So every day things change. Even during the COVID period, patients deterioration or patient status does change every day. So you have to check your sats 4 times a day. You make sure that tell them that if they deteriorate, only then they need to come to hospital. They don't need to panic. What measures they can have to make themselves better, what's the best position they can check their sats, and all these sort of education, I think, is very, very important to let people know. So I think that's all from my end. It's not much to say, which we have already spoken about. It's more of an ITU management when the people go to ITU, but on the emergency medicine, we are the ones who would recognize that this patient needs to come in, this patient does not need to come in, and what advice we send them home to. So rest of the medication is all intensive care medicine, and obviously we are not talking about that, but yeah, the
yeah.
list goes on and on. Is that okay?
Yeah, I think that's a good session. Um, we will upload it on YouTube so that can be watched. Inshallah.
Okay.
The
So inshallah,
main
we'll have
theme is,
next week.
yeah, inshallah, I'll float the idea. Main thing is
Okay.
get vaccinated on whichever vaccine you can get your hands on and get 2 doses in. So you can have at least, even if you get exposed, you do not develop severe illness that requires intubation or ICU admission.
Yeah. And
So
I think
that's,
it's very also encourage your elderly family members to have the vaccination who are very, very stubborn, not listening
yeah.
to the advice. So take them. I think there are lots of good centers in Pakistan now who are trying to vaccinate people now at the age of 40 now. I think they've started.
Yes,
So
yes,
yeah,
yes.
the
So
sooner
that's,
that we get all vaccinated, herd immunity will develop and then we will get better. Hopefully things get better. So yes, thank you very much for that. I will